So arthritis can develop a couple of ways. You can have abnormal anatomy. Maybe you were born with a dislocated hip as an infant. Abnormal biology. Maybe you don't have good blood flow to the femoral head. That's a condition known as avascular necrosis. Maybe just overuse. You just were, a laborer for your whole life and you just kind of wore out the hip. And then there's genetics. And I think this is probably the most common. It's very common that we'll hear people say, oh, my dad needed knee replacements too. And now my knees are bad. And so, or my brother had a hip replacement 3 years ago. Now I'm getting a hip replacement. So that's pretty common as well. We haven't necessarily figured that part of it out, but there certainly seems to be a major genetic component. So again, what causes pain in arthritis? It's that cushion at the end of the bone covered with cartilage that allows the joint to function without pain. And when that cushion breaks down, that's what arthritis is. And so I liken it to a normal functioning joint. To a new door hinge. This is a new door hinge in a new house. It's shiny, it's well lubricated, it's got full range of motion, no pain, no cracking, no creaking. And then you just take like life, right? Normal function, you take it for granted, getting in and out of a car, sleeping without pain, things like that. And, exercise, enjoying life, all these things. And then all of a sudden you lose that. And what happened? Well, what happened was now this door hinge is rusted. The door doesn't open as much as it used to, so the range of motion has decreased. Even makes noises now when it moves, like little creaks and cracks, right? If anybody can relate to that, that's kind of how I relate an arthritic joint. So when we ask people about their hip pain, do we ask if they limp? The number one thing I'll ask is, do you have difficulty putting on socks or shoes? That's really common because with hip arthritis, the number one sign is a loss of range of motion. Pain can limit activities and lifestyle. One leg can feel shorter. Patients can have balance problems. Patients with hip arthritis will often have pain in the thigh, the groin, or the butt. They can also have pain that radiates down to the knee. So how can we treat the pain of hip arthritis? Well, water therapy, heat, hot tub, ice pack, whatever, those things work. Exercise and physical therapy are good for weight loss and just good for your joint health in general, believe it or not. So even if you have an arthritic hip, exercise and movement are still good for it. And I would say an exercise bike is a really good way to exercise when you have an arthritic hip. Medications, anti-inflammatories like Tylenol, Motrin, Aleve, naproxen, all those medications can help. And then you can even do a steroid injection in the hip joint. I prefer to have them done under an X-ray or ultrasound. And that can decrease inflammation with the local medication right there in the joint. But at some point, the truth of arthritis is the non-operative treatments will fail. And so when that happens, you can do a hip replacement for the hip. Basically, the implants replace the damaged surfaces, and the surgery helps to relieve pain and improve mobility. This number's from 2009. My guess is this is close to doubled in that we're probably at 500,000 or 600,000 hip replacements in the United States every year. So what's a hip replacement? Well, look, you take this picture from where we started, right? Here's your ball on top of your femur. Here's your socket of your acetabulum. And here's what a hip replacement looks like. It's pretty similar. Okay, you have a metal stem that's inside of your femur. You have a ball that articulates with that. And then you have a metal shell that's in the pelvis that kind of recreates your pelvis with a plastic liner. And that's what a hip replacement is. So if we show you on an X-ray, here's an arthritic hip. There's bone-on-bone arthritis right here. There's cysts. There's hardening of the bone. And then with a hip replacement, what we do is we make a cut right about here on the bone. Okay, we take this bone, throw it away, and then we put a metal stem inside the femur, a metal shell inside the pelvis, and a ball to articulate with a liner inside the shell. So one of the things we do at Capitol Health is we do what's called an anterior approach. If you look at most people who have had hip replacements, a lot of them will have incisions that are on the side of their leg or towards their butt. An anterior approach, the incision is made on the front. And the nice thing about this approach is you can get through to the hip joint without cutting any muscle or tendons. So the hope is that you'll have a little bit of a faster recovery. Studies will show maybe, doing a little better at 2 or 3 weeks, but doing about the same at 6 weeks. So it's not significant. But what I think is nice about it is in a traditional hip surgery, people are lying on their side. Patients are lying on their side. And so a lot of times we're looking at their leg lengths or the position of the implants after the surgery. With an anterior approach, it's nice. We use this torture device, also known as a traction table. Don't worry, the patient's under anesthesia, so they can't actually feel anything. And then we can use an X-ray intraoperatively to see where the components are and kind of assess leg length. So that's really helpful. Patients will say that hip replacement is a wildly successful surgery. It's been dubbed the operation of the last century. 96 to 97% of people do great after the surgery and are very happy they did it. Very, very high success rate in hip replacement. So in summary, the leading cause of hip pain is arthritis, and it's a degenerative condition that won't get better and might get worse. Early diagnosis and treatment of arthritis are important, and hip replacement can help relieve pain and improve mobility. So moving on to the knee. So the knee is the biggest joint in the body. It's made up of three main bones, the thigh bone or femur, the shin bone to the tibia, and the kneecap or the patella. And then the cartilage is in between these bones, and that's what allows you to move without pain. So again, same thing, arthritis is the most common cause of knee pain. Rheumatoid or inflammatory arthritises are also common. And so same thing, the end of each bone is covered with cartilage, acts like a cushion, and when that cartilage breaks down, then it leads to bone-on-bone contact, soreness, and swelling. So here's a picture of like what an arthritic knee might look like here, where you can see here's the white stuff is cartilage, and then these areas are damaged cartilage. Here's an x-ray of a normal-looking knee. There's nice black space between the bones, the femur here and the tibia here. And then here's an arthritic knee, where there's no black space between the bones. That's bone-on-bone arthritis. So we ask patients when talking about their knee pain, does it hurt more than one time a week? Do you have trouble sleeping? How far can you walk? Are the conservative treatments like medications or steroid injections not helping? Has inactivity from the pain caused you to gain weight? These are all important questions to help us assess how badly you're affected by your knee arthritis. So treatment's pretty similar, right? Water therapy, soaking, heat, ice, hot tub, cold tub, medications like anti-inflammatories, steroid injections, exercise and physical therapy are very helpful. Other types of injections like hyaluronic or viscous supplementation injections, these are not FDA approved for the hip, which is why I didn't talk about them. But basically, these are synthetic joint fluid that you inject into the knee, very similarly to the way cortisone or a steroid goes into the knee joint, and they can decrease inflammation, but they can also stimulate the cells around the joint to produce more fluid and lubricate the joint. I liken the visco injections to WD-40. Most people seem to get what that is. So when these non-operative treatments fail, you can do a knee replacement. And in a knee replacement, it's probably more like a resurfacing. You're basically just resurfacing those damaged surfaces. Again, a very successful surgery. Probably at this point, I bet you were over $1 million a year in the United States. So here's what a knee replacement looks like. There's metal, this white here is metal on the femur, this white here is metal on the tibia, and then there's a piece of plastic on the in between. That's clear, it doesn't come up on x-ray. So if we look at this is the femoral component sitting on the femur. All this stuff is the patient's bone. So it's really just removing about a centimeter of bone so the implant can fit there. The tibia, same thing. Here's the tibia sitting on top, tibial component right here, and metal sitting on top of the tibia. And then there's a piece of plastic in between. So again, healthy knee with black space between the bones, and then here's a knee replacement. There's black space between the bones, between the implants, but that's actually a plastic piece that goes in the middle. So in summary, the leading cause of knee pain is arthritis. Again, a degenerative condition that won't get better, might get worse. Early diagnosis and treatment for knee replacement are more important than hip replacement in my mind, because there's more options for knee arthritis and more opportunity to treat it non-surgically. It's a very highly satisfaction gaining procedure for patients. And so it can do really well for a lot of people. You know, my goal as a surgeon is I want patients to come back 3-4 months after surgery and tell me, you know, doc, I wish I'd have done this sooner. And that's the ultimate win there, because, you know, you realize you can actually help someone and you realize they realize how limited they were, and now they're actually better, which is great. So what can someone expect after a joint replacement? You know, a hospital stay, probably a night, sometimes going home the same day. Recovery, it's going to take probably 2 to 4 months for a lot of that swelling, stiffness, a lot of that nighttime pain to go away. Pain control, really important. We use a lot of different medications, not just narcotics to help, and opioids to help with pain control. Nausea control is really important because all the anesthesia, the medications can make you nauseous. And then if you're nauseous, you can't do your therapy. Therapy's huge. You got to do your therapy to get better after a knee replacement. Hip replacement, you can kind of do more of a self-guided exercise program. And then return to work. I recommend everybody take 3 months out of work for these surgeries. I think they're big surgeries and it's a long recovery. And to try to go back to work too soon could actually make your recovery worse. But, you know, times have changed. And now with COVID, A lot of people can work remotely, so maybe there is more option to get back sooner, especially if we have a remote job. And so outpatient joint replacement, what is it? Well, it's pretty much what it says. It's having a joint replacement and going home the same day. It's more common now because during COVID we had to do it because we didn't have enough beds in the hospital to have patients stay in the hospital. So we were sort of now outpatient surgery has been done for a number of years in joint replacement, but we were sort of all as a field pushed more towards this during COVID. And so what we found is it's pretty effective and patients tend to be pretty happy. And who's a candidate for it? It's really going to be the healthiest of the healthy patients, because we don't want someone going home and having a medical complication or needing to go back to the ER because something's wrong. So it tends to be younger, healthier patients, but it's really a great way to have your hip or knee replaced. So when we talk about hip or knee replacement in general, but also talking about outpatient hip or knee replacement, one of the big things is education and expectations. It's really important the patient and their family have appropriate expectations. So number one, patient selection is really important, really the healthiest of the healthy. So the lower risk patients, nicotine free, no diabetes or having it be well controlled, no anemia, normal weight. We do a lot of things to prevent infection, like nasal swabs and cleaning with like Hibiclens wipes. If you've had surgery in the last few years, you've probably had them. And then very important to have the room and instrument cleaned well to really decrease that risk of infection. The patients really need to be prepared. There needs to be that mental preparation, like, hey, this might stink, but I need to plow through it. Sometimes it's helpful to have a caregiver or a coach. But my goal for safety and education is so that the patients have no questions after surgery. So I give everybody a packet, and my hope is the patients read it because I think it answers most of the questions after surgery. Patients, we all really fear the unknown. So if we're going into a surgery and we don't know what to expect, that makes it probably more anxiety provoking. So if you have an idea, hey, this is going to hurt. If you have an idea that, yeah, you might depend on others, but people are there for you. If you have an idea that, yeah, you're probably going to get back to driving for 2 to 3 weeks, you're not going to get back to work for 3 months. It's helpful to know all that. And as far as when will I feel normal, it takes a while for that to happen. Maximum relief from a knee or hip replacement might take up to a year after the surgery. So in outpatient joint replacement, we do what's called multimodal analgesia. That simply means we hit the pain that you might have in different ways. And so we do medication before, during, and after surgery. We do different types of medications. We do anti-inflammatories, nerve pain medications, Tylenol, even some narcotics as well. But the hope is that if we can minimize narcotics, patients will have less nausea and they'll get up and they'll move quicker. And they'll be hopefully less prone to being on narcotics, well after the surgery. So for outpatient joint replacement, it's really important that we all work as a team. So physical therapy helps. Sometimes it's good to go to therapy pre-op. For the medical equipment you might need, the facility and the therapist can plan ahead. If we need to, we'll have PT come see patients in the recovery room instead of waiting to go to another room if there's a bed issue. And then at the hospital, we actually have stairs that you can practice on. So if you have stairs and you're concerned, you can work with a therapist on the steps before you go home and climb that flight of steps. So the number one question I get asked in all these lectures is, how can I prevent a joint replacement? And then number 1 and 2 ways are to stay active with an exercise program. And number 2 is weight control. Don't get heavy. It's simple physics that for every pound you have on the top part of your body, that's 7 pounds of force on your knee, 4 on the hip, 10 on the ankle. So really important, if you don't want to wear those joints out, to try to limit how much they're being used. And by controlling the weight, you can do that. That was all I had for you guys. Thank you very much for listening. And I figured we could just go right to the chat and see what questions people have. So I'll start at the top here. Please make sure you do the survey. It's really helpful for Marcia and the community education team to figure out what the community wants to learn about. A question about meralgia paresthesia, or probably meralgia paresthetica. I was not going to cover that. That's a pretty rare complication of really any surgery. But most commonly hip surgery, where a nerve can get irritated after the surgery, and it's pretty tough to treat. I might have seen it once or twice in my career. What materials are used for knee replacements, and can people be allergic? Most commonly for knee replacements, we use a metal alloy, which is mostly cobalt chromium, but there's usually nickel in it as well, and people can be allergic to that. So there are options for those types of patients. We can use an implant covered in a ceramic coating, and that will hopefully decrease the exposure to the The nickel, which people can be allergic to. Usually you'll know if you're allergic to nickel if you're like allergic to cheap jewelry, or if like you get a green spot under your watch that you might wear. Or maybe, yeah, those are the really two main ways. You can also do a lab test as well. Someone asked about blood thinners. How long before and after these are back? They take Xarelto and Plavix or clopidogrel. Great question. Something we deal with all the time. And basically, you'll be off the Plavix 7 days before surgery. There's a Xarelto 3 days before surgery, and we'll start them both back the next day after surgery. Do ligaments always have to be cut? Yes. The ACL, there's a small subset of implants in which you don't have to cut the anterior cruciate ligament in an ACL. I don't think the outcome on those are great, so I think that'll continue to kind of dwindle. But yes, the ACL pretty much almost always has to be cut in the knee replacement. Someone had a TURP, which is a transurethral, I think, a prostate removal. So how soon can you get a hip replacement? Usually you just want to be recovered from your other surgeries before you do a hip replacement. It's a big deal. So I would say, something like 6, 12 weeks, something like that. And you want to make sure you're not having bringing complications from one procedure to another. Can you have a knee replacement if you have had Osgood-Schlatter? Yes, that's basically like kid tendonitis for the knee, and you can have a knee replacement. And is there a way to minimize the effects of a Baker cyst behind the knee? Baker cysts can be really annoying for patients, but interestingly enough, most often they're just incidental findings, and they actually don't cause that much pain. It's probably more just the underlying arthritis. But you can have a Baker cyst aspirated or drained. The problem is they usually just come right back. So the better way to do it is to treat the problem. So a Baker cyst is a cyst in the back part of the knee that usually forms because there's a lot of inflammation in the knee and fluid leaks out the back of the knee. If you can stop that, that fluid from leaking, that helps. And you stop that by treating the reason it's coming back, which is usually a meniscus tear or arthritis. Someone had a question about breast reduction before knee replacement. I think that could be helpful. I mean, breast reduction before will just take weight off your knees, and that might help your knee arthritis. So if someone has multiple problems, sometimes people actually get surgeries to get ready for their hip or knee replacements. Best treatment for runner's knee, which is really more of a sports injury. It's called IT band syndrome. Usually the best treatment for that is stretching or physical therapy. So hopefully if you have that issue, you can get into a program for that.
Any other questions people have? It looks like that might be it. Again, if you can complete the survey, I will be staying around for the next 5-10 minutes. So you will have time to complete that. I really appreciate it. And I want to thank Dr. Saxena for coming and speaking tonight. Oh, it looks like there might be another question.
Oh, how long can you take shots before surgery? Well, if you're talking about alcohol, you can do it like 3 days before. But if you're talking about knee injections, a steroid injection, usually you want to wait 3 months before surgery. The gel injections, there's really no hard and fast rule. Probably if you get a gel injection, you want to at least give it a month to see if it works. And then if you're scheduling a surgery, maybe 2 to 6 weeks after that, that's probably pretty reasonable. But you can have injections before surgery. You just have to time them right, especially if they're steroid injections. Another question, how long does knee and hip replacement last? We have good data that shows 80 to 90% of the time that a hip or knee replacement will last 20 years. And so they're not failing year 20 and day one. So we hope that as time goes on, we'll get even better follow-up. A hip replacement, knee replacement, depends on the situation. As far as the patient, their body habit is, how bad their arthritis is. But, on average, both surgeries will take about an hour.
There was a question about the survey. You might have to just scroll up a little bit.
It's all the way up at the top. Yep.
I put it in like 3 or 4 times, but you probably have to just scroll right above some of the questions. If you need it again, let me just put it in so you can get it more. It kind of changed the Zoom setup, which makes it a little more.
Question about having a colonoscopy. When can you have a knee replacement? Probably I'd wait like 30 days for any like major surgery or even a minor procedure to have a knee replacement. You just want to make sure you get through that other procedure and don't have any complications there. But there's no hard and fast rule there. Can hip replacement be done at age 87? Yes, it absolutely can. It's all about your quality of life and how healthy you are. So certainly taking into account, your health. Are you physiologically more like 67 with your heart and lungs, or are you more like 107? And so we do know that the older people get, the higher the complication rate is. But if we go through everything in a prudent fashion, talk to your primary care doctor, get all the appropriate tests, we can minimize the risk as patients get older. And then, unfortunately, at some point, you just got to hope for the best. But I have done hip replacements, elective hip replacements, not for hip fracture. I've done elective hip replacements in 87-year-olds, 91-year-old, even a 95-year-old. Next question was, how many times can you get a steroid injection in the knee? You can do that as many times as you want. I would tell people you should be spacing them out every 3 months. And I would also tell people the more you get, the less effective they end up being. So it's sort of a diminishing improvement as time goes on. Same thing, knee replacements, 80 to 90% of the time, they'll last 20 years. All right, well, a lot of really good questions. Hopefully this kind of spurred some thought up for people and gave some people some ideas on what they may be able to do with their hip and knee arthritis and their hip and knee pain. Marsha, I want to thank you and Capitol Health. Really important to educate the community on their health. That's one of my passions, to educate my patients. So thank you for the opportunity.
And thank you very much. It's a very popular topic.
All right, thanks, guys. Everyone have a great day.